spine disease then. Okay. So we'll start talking about degenerative changes. I don't need to go into that. So I'd like to just give a little bit of an introduction here before we get into. This is just from a paper that was published a couple of years ago that reviewed health-related statistics from 1997 to 2005 having to do with lumbar spine. And it looked at adult patients in a very large database, those who had a diagnosed as a spine problem, and those who didn't, and these are almost all lumbar spines. And it looked at the cost per year of their overall medical care. And as you can see here, what turns out is if you have a diagnosis of a spine problem, then the cost of your medical care doubles compared to all the people who do not have a spine problem. So that diagnosis is a very expensive diagnosis. And this is some of the data associated with it. And then what they found is in 1997, if they looked at functional limitations in these individuals, about 20% had functional limitations in 1997. And actually, as time went along, even though the cost of care for spine patients increased, almost doubled in this time period, or I mean, not almost, but significantly increased in the time period, the actual outcomes in these patients actually got worse. More people had functional limitations than not. Though we substantially increased the cost of taking care of patients with spine problems from 1997 to 2005, the actual outcomes in those patients worsened over that time. So this brought up, they're basically, this was in JAMA, they said that spine problems may be offer an opportunity for us both to decrease the cost of medicine and actually improve patient outcomes rather than having them worse. And around this same time period, there were these kind of ads in the Los Angeles Times, which this was an advertisement basically advertising from attorneys and from non-operative workman's comp clinical operations to basically warn people not to see spine surgeons if you have spine disease. If we kind of look at the epidemiology, a study in Spine in 2003 showed that if you look at areas of the country, there was a substantial variation in the rates of getting MRI for spine disease. It was very high in large cities and very low if you got outside of large cities. And then if you actually then looked at the rate of spine interventional studies, either pain management or surgery, you found that the interventional rates correlated well with the rates of MRI. So areas where MRI was high, interventional rates went very high. And then they looked at patients who got MRIs versus patients who only got X-rays in their evaluation. They really found no difference in the severity of their symptoms, but patients who got an MRI had much higher surgery rates. But if you looked at them in 1 year, the increased surgery rates had no impact upon their outcomes. And so this article basically says the #1 strategy to decrease spine interventional rates is to limit MRI availability. And actually what happened right after this paper was published is that a lot of the insurance companies started putting severe limitations on the ability of people to order MRIs of the spine, because the data really suggested that it was driving higher surgical rates but not improving patient outcomes. So think about that when we go through all of these things. And I think a lot of that is, as John said before, virtually everyone who's over 15 who has an MR scan of the lumbar spine, you'll find something that's abnormal. The important thing that a radiologist needs to do is not just say whether it's abnormal, but to actually say whether it's significant. And therefore, I feel that more of an onus is on us, the radiologists, to try to make that distinction in the reports. That's hard to do because a major driver of ordering MRs has been spine surgeons who want to do surgery. And therefore, if you, there are a lot of radiologists will word their reports to increase the likelihood of having spine surgery because it helps drive their own business. So it's a dilemma that we have to deal with, that you're both in your own practices are going to have to think about as you go forward.
So that's good. When the JAMA report said all of this, did they say?
Unfortunately, you guys don't order the MRI. The clinicians do, and the clinicians that order MRIs, if I were to guess, probably 75 to 90% of the clinicians that are non-orthopedic or non-neurosurgical folks don't know why they're ordering the MRI at all, because they don't know how to examine a patient and they don't know how to treat the patient before they order an MRI, and they just do that because they can, and the radiologist compensates some of these folks very well. I've seen it. I know about it, and the surgery and these folks, as we go on, you'll see what the results are. So, but when you're getting to the papers, especially papers like JAMA, JAMA has a tendency to write stuff that's pretty well. I don't want to say pretty bad or whatever, but the studies are not that great. Probably if you want to get a feel for what kind of surgery should be done and what kind of studies, you go to Spine. Spine is a good journal, and you go to JBJS. So anyway, I think we'll be repeating this as time goes on.
Thanks, John.
I'm just wondering if currently we're still overutilizing MRI for spine. It sounds like we are, and if so, like what are the real indications? Overutilizing MR for spine issues. Okay.
We'll talk about criteria for it. Yeah. So we'll come back to that. Good. So in our basic protocol, which you've all seen looking at, we typically do a T1 sagittal, T2 a stir, T1 axial, T2 axial. This is pretty common, pretty standard. A lot of people like to include a coronal, especially if the patient has scoliosis, which I think is fine. Personally, if it's known scoliosis, I really like to get a dedicated coronal. Otherwise, there is a coronal that comes with the scout that can be helpful. But this is our standard protocol is 5 sequences. Special protocols, you can give contrast. Historically, people said contrast was helpful to differentiating post-operative and post-operative changes to evaluate disc versus scar. I'm no longer a believer in this, but we'll talk about this and we'll go through the use of contrast. I think that contrast is not very valuable, and it doubles the cost of the examination. Certainly contrast is helpful if you're having soft tissue masses and neoplasms. It's not very helpful for bone neoplasms, in my opinion. I'll also talk about upright flexion and extension views. We did a big study with an upright scanner where people could upright, and I'll talk about potential uses of that as well. Okay, so this is back pain in a patient who was in an auto accident, and this is now the patient is suing to get more compensation. What do you think?
Okay. So we have disc desiccation at, I think, L4, L5, if we consider that a transition. And yeah, we have central disc protrusion. Okay. And I would say like minimal spinal canal narrowing, no significant neural foramina stenosis.
And that's the next level down.
Okay, that's L5S1, or is it Okay. I'm not sure if they have like 6 lumbar vertebrae. This is a transitional vertebrae or what. Okay.
So I'm glad that you thought about that. This is a bulge, and it was called, at the time of the study, they called this the L5S1 level.
Okay.
What's one of excuse me, what's one of the things you want to know about this bulge or protrusion in terms of history?
If it's acute or not, if there was a trauma.
Well, trauma rarely causes disc protrusions. That's a myth. What you want to know is how old is this lesion?
Okay.
And then you can look back at the car accident and get an idea. Did the car accident precipitate this problem, which is extremely, well, not extremely, but quite rare.
Okay.
Okay.
So anyway, I just wanted to alert you in litigation cases, you want to know the age of the accident in terms of when symptoms started, etc. Now, is that your problem? No, the clinician's problem, but I think you can help by having the technician ask and put on a report how old the lesion is.
Good. I agree, John. Okay, so this was called L5S1, and here's the next series of images that we have.
Okay, I think this is in the OR. They're trying to localize, and they are, I think, localizing the next. That's a screw. Did they fix it or?
Okay, so what level did they operate on?
I think they level below that.
Okay. All right, and then here are further study.
And what do you think about that device that's in there?
I have no idea what's that actually.
So
how do they fix it?
So this
that must have been done in Russia, John.
It wasn't. It was done in Southern California. So what happened is they went in to do surgery at the level the radiologist said, which they thought was L5S1. They used the plain films to determine what L5S1 was, and they said this was L5S1. So they went in to do the surgery, and they found they couldn't do the standard surgery because there wasn't enough space. They wanted to put in an artificial disc, and we'll talk about artificial discs. So they ended up trying to fuse the L5S1 level, and what we can see here is that they actually operated at the wrong level. So I'm pointing this out now is that you got to be very careful when you determine levels. And
that screw cannot hold a feather.
Yeah, but John, they actually fused a very stable level, so that wasn't the problem.
I understand, John, but that's pathetic. I don't know who these folks were with.
Right. Well,
but I'm not going to start swearing on the internet.
Yeah, I think you know them, but I won't go into that.
Yeah, I got it.
So, and it turned out if you follow this down, and we'll talk about congenital variants here as we go forward. The lateral processes here actually articulated with the lower level, and this was really a lumbarized S1 vertebral body. And so, in situations like this, it's always important to try to make sure the levels, especially this is really too small, and we didn't see there's no disc extrusion here. This is a very narrow disc. So when you see that, you've got to be very concerned that you may be dealing with a very common congenital variant at the L5S1 level. So if you can, try to go up and see where T12 is and then count down. If you do that, this would be L5. And then also you need to look at the lateral processes at the lowest level to see whether they're fused with the sacrum or not. By far the most common symptomatic lesion that I've seen missed is one where you have partial sacralization of the L5 vertebral body with S1. We'll talk about that. There's a syndrome name for it. Very commonly missed. And so this area is very important. In this particular case, the radiologist was looking at this level to be L5S1, but in the report it really wasn't clear that they were looking at this as being a partially lumbarized S1, and therefore the confusion went into the OR, and they actually fused the wrong level, and there was actually an MR scan that was done later because the patient continued to have symptoms, which actually showed that the L5S1 disc protrusion was unchanged and all the surgery was at the S12 level. And then this was all a litigated case. But when I saw it and saw that, it hadn't been noticed that the surgery was at the wrong level, and it became really a mess in litigation. So and it just turned out that they were litigating over paying for the cost of the surgery, and the insurance company saying the surgery wasn't necessary. And then when they realized that the surgery was actually at a level that was different from what was intended, it really became a mess. So just the radiologist was actually right in saying it was the L5S1 level, but they didn't clarify the potential confusion enough so that they actually did surgery at the wrong level. So I just want to point out how important it is to make sure that you clarify that in your reports. Okay.
Well, one thing I think, John, when you're looking at sacralization of L5 on S1, not complete sacralization, but incomplete, like one side. I think X-rays are probably better in showing that problem than MRI, at least in my opinion, from my experience.
Okay.
I don't know what your experience is.
Well, X-rays can be very helpful because you can see the lowest ribs on X-ray, and we can't always see that on an MR scan. The
Right.
Anatomy
And if you're
can be seen
also, if you're going, I'm sorry, if you're going to operate on the spine, you better damn well get the lower thoracic area before you cut on the spine.
Okay, good. Okay, Shiv, what do you think of this case?
Okay, 66-year-old anticoagulated with left hip prosthesis and left-sided back pain, rule out discitis or epidural infection. So, actual lumbar spine doesn't look horrible. I don't see any fluid collection within the spinal canal or in the epidural space. Could be something going on the left side there.
Okay,
I want a larger field of view to see what that is. Okay, so it looks like sort of a heterogeneous collection in the bursa over there. Looks like.
And there's actually the hip joint. Here's the prosthesis, and you can see all this fluid around it. And this was a hemorrhagic bursitis of the iliopsoas bursa, and that was the cause of the problem. So just realize that sometimes other things besides what you're specifically maybe looking for may be an issue, especially if the person has a complicated history with anticoagulation. And then we'll talk about muscle atrophy. Again, this is an area where I think you should always comment on the integrity of the spina erecti muscles, because I think probably most back pain actually comes from the muscles and ligaments, as we'll talk about, not the discs. And that's completely ignored by most people. Okay. Oh, and then, so disc enhancer, we used to do a lot of MR with and without contrast for the lumbar spine in postoperative patients. Here's just an example. Here we can see here's a little disc protrusion. We'll talk about what a protrusion is in a minute. And then we can see that this is T1 pre. This is actually a T2, which we can see a little bit of increased signal intensity within the disc. I'm sorry, this is a T1 post. And then shows enhancement of the disc there. This patient, however, never had surgery, so this wasn't scar tissue, which is what we typically see. And it turns out that enhancement of tears in discs is quite common, even if you haven't had surgery. So the old concept was if you see enhancement after surgery, that's scar tissue and you shouldn't operate on it. And if it doesn't enhance, that's disc and you should operate on it. As we'll see when we go through here, I think both of those are wrong. And and in particular, if you have a disc tear, you get hyperaerobic response and you get granulation tissue to heal it, just like you do anywhere else, and that can enhance with contrast. So, so that old concept about using enhancement to determine if it does enhance, you don't operate. If it does enhance, you may operate. I think is not a valuable concept, and this just shows that enhancement of that disc in someone who's not had surgery.
That goes back to the Middle Ages, doesn't it, John?
Pretty much. Prehistory in the MR era.
Yeah.
You wouldn't necessarily see an annular fissure on a stirring, interestingly.
An annular fissure, we'll talk about annular fissures.
No, in those cases where there's enhancement because of an acute tear of the disc, you don't necessarily see an annular fissure.
Annular fissure is a completely different thing. We'll talk about those.
Question. Somebody's talking. I'm not.
Yes.
Somebody's talking away from the mic.
Yes, sorry, that was me.
Okay. Foot drop for 5 years. Right off the bat, what are you thinking? Can you fix it?
No, I guess if it's no. I mean, it's that nerve is. I would imagine that nerve is gone for 5 years.
Even if it's a shorter time than that, you cannot bring it back when it's gone.
How
you
long?
better catch it before it gets there.
How long?
There's no set time limit. As soon as you see a foot drop, I would operate. Mainly, the thing what you watch for is progression, and test the patient and examine the patient. The biggest problem I have seen in the recent times, and I've seen too damn many doctors lately. I'm sorry to use the term, but then I include myself in that situation since I happen to be a doctor too. Just they don't examine the patients, and that's the problem. And you're not going to pick up a foot drop on an MRI.
Yeah, that's true.
I dare you to pick up a foot drop on an MRI. And when we were kids, we used to say double dare, didn't we? Yeah. Anyway, so ergo, the only, I'm going to say this right now, so before I forget, the only reason to operate on a back is progressive neurologic deficit. Pain is not a reason to operate, and most of the time, people are operated for pain. And that's when they get reoperated. And a friend of mine, not too long ago, he died. I told him, don't have the next 4 operations. He started out with 1, a laminectomy, failed. I said, don't have the next one. He went on and had 4 more, and then died of congestive heart failure. But his back never got better. He never fused completely, and the surgeon was a different one each time. So who do you hang? I don't know.
Okay, thanks, John.
Thank you. So there's a lot going on here. I don't know if there's necessarily any narrowing because I don't know what section we're going through here.
So this is the T2 in the stern. Here are the T1 pre and a T1 fat set post. Obviously
Okay.
Not my protocol.
Yeah. Well, there's something enhancing. I think. Well, I mean, I'm assuming they're enhancing because it's really, really bright. Yeah, those things in the predominantly the epidural, I think epidural spaces. Yeah. Yeah, so that it may or may not be disc. I mean, it's right over the disc. It could be, I guess, based on what you just said. That's a lot of enhancement.
And here's the T1 axial freedom post.
That looks like disc.
Tiny little bit of disc.
Yeah.
And that's a T2 axial.
Yeah.
Okay. And this, again, extensive disc enhancement, but this patient never had. So I just.
But that's granulation tissue, isn't it, John?
Right, that's granulation tissue. But I just want to show that the common explanation for why we give contrast in the past for postoperative spines really doesn't make sense.
Wouldn't scar be low on T2, whereas these things would be bright on T2?
Scar depends upon the age of the scar. If you have subacute scar for quite some time before it becomes heavily fibrotic, then it has a lot of granulation tissue in it, and it's bright on T2 and it enhances. When it's really burned out, then it becomes just fibrous tissue and it's dark. Yes, John?
Question. How long does it take for tissue to heal completely? And I'm talking about any tissue in the body.
Any tissue. I guess I would think that it depends on the tissue, but maybe.
Well, to some extent it does. Maybe. But when you look at everything and you look at it microscopically, it actually takes between 6 months to a year to mature. Scar tissue. Even a knife wound and a forearm, or obviously the head heals faster, etc. But actually, for maturity of scar tissue, it takes 6 to 12 months.
Okay.
And in some folks, maybe longer.
Yep. Thanks, John. Here's just a case showing a T1 weighted image, and then here we can just see the epidural space in this particular patient. So there have been a number of different designs for upright scanners. This is one that was a GE design. I think they made about 30 of these. This was a 0.5 Tesla machine, and it had a big magnet over here, a big magnet over there, and this is back in the 1980s, and it was thought that one of the big problems with being able to evaluate spines is you really need the loaded spine. So the concept was at those times that you really needed to have an upright machine in order to get really physiologic imaging, or kind of physiologic imaging of the spine. So this was an upright scanner. This actually comes from a different scanner, a phonar scanner, which also could be done upright. And we did a series of studies. If people stand up, they move too much, and it feels all you get is a blurrogram. So what we did in lieu of that to get the studies was that we had people sit on a platform. So they were still upright, but that their tail was supported on a stool, or it was actually a shelf built into the scanner, and then they could flex, neutral, and extend. And then this obviously could be helpful if you have instability, so you could see movement. And you could do flexion, neutral, and extension. You can also do this with x-rays, as you all know, or even do it fluoroscopically. So this is a patient where we did this, and here we can see this is a situation where in a flex view, we can see the spine here and the nerve roots. This patient had prior surgery and had some clumping here. We'll talk about that later. In extension was what we could see is that the fluid here in the facet joint actually extended into a cyst that went into the area of the thecal sac and compressed the thecal sac. So we did see some changes between flexion and extension. In this particular case, this patient had more symptoms in extension, so maybe the fact that you got some central stenosis in extension due to the fluid in this cyst may be possibly symptomatic. So that's one thing that we saw. Primarily what we were looking for, however, was to see with flexion and extension, you saw a difference in disc protrusions. The concept being that if you put more pressure on the disc, it would protrude and therefore produce compression of nerve roots. One thing that we did see is that these facet cysts could be more prominent in extension.
If I was to give my experience, people have pain more in the evening and before they go to bed than say after breakfast. And the reason being is that we're shorter when we go to bed than when we wake up. And then that causes the discs to bulge as the day goes on. So flexion and extension, you do that during the day, pretty much all day long, in one way or another. I think people vary in terms of what causes the pain, flexion or extension. That's a real situation, but I don't think that the MR is going to really help you that much, unless you want to do the MR in the morning or at night or after activity. I think that would be far more effective in terms of what you find.
Thanks, John. And I'll give you the results of what we found a little bit later. It's in line with what you just said.
Can I ask a question about that foot drop case? I didn't quite understand what the...
Here, as all I'm showing is that you can get, I just want to point out that in this case, you can get enhancement of discs.
Okay, so that's all disc.
Without having surgery. And that just because something around a disc enhances doesn't mean it's scar tissue. And again, the reason that's important is that the old theory was you gave with and without contrast after surgery. If it enhanced, it was scar tissue, and therefore the patient had no indication for recurrent surgery. If it did not enhance, it was disc, and they should go in and reoperate on them. There are other reasons why I don't like that theory, but I want to point out that just because something enhances doesn't mean it's scar tissue.
So I have a question here. Like, is this like the disc height looks fine, and does it a disc condition or prominent epidural vein, or sometimes you see that bit is crossing the both side, disc upper and lower?
Okay, here's the axial image through that area.
So it's disc.
So these were little disc herniations that you could see coming out through a tear in the ankle in this particular case, and granulation tissue in this area of disc. There's a T2 showing it. So
Got it. Thank you.
I don't think it was veins. Right. Okay, so let's go on to other. Now, this is more a technical area. I'll go into the detail. I just want to show technical aspects of doing the imaging and some technical problems. Who's next? I don't know. Sahar, you do. Okay. Okay. So what do we see here?
Hi, Dr. Cruz. It's Pablo.
Oh, hi, Pablo. Oh, so I skipped Hamid also. So, okay.
So axial images through the spine, there is abnormal increasing intensity within the left side of the left posterior aspect of the vertebral body. So
what is this? Now notice this is, yeah, I don't know if you see through many, this is a low field scanner, which is also a little bit important to know.
So it could be, a lot of things. It's a
kind of doesn't really look like a typical lesion.
Right. Any artifact then?
Okay, so this is actually a flow artifact from flow in the aorta, which is displaced in the phase-encoded direction and shows increased signal intensity right overlying the vertebral body here. So just be aware of, like we've seen other areas, you can get flow artifact, and you've got to be careful of which direction your phase encoding is. And as I said before, I always like to do the phase encoding right to left, so that any flow artifacts from the great vessels don't project over the vertebral bodies. So just...
That's not an aneurysm.
Yeah, right. So that's perfect. Now, we all know this stuff. I'm not going to go through this stuff. This is for someone else. Forget this. And you all know about monograms. Sorry about this. Oh, okay. Let me see. Pablo, what do you think of this case? This is a T1 weighted pre and a T1 weighted post.
Okay, so post-op scar and question of when. So there's this iso-intense in the right side of the, looks like it's the epidural space and posterior to the disc, which I think shows enhancement with a central hypointensity in the post-contrast image. Well, one of the things it would be scar, but I wonder if there could be extruded disc, like you explained, with scar tissue, granulation tissue.
So we'll get to the clinical reports that have been later about disc extrusions. As well actually. So this is actually an extruded piece of disc, and this is the scar tissue around it. We can see the mid-laminectomy defect right through here. This could also be a dilated nerve root, because you can also get nerve root irritation in this area, but this turned out to be an extruded fragment. And we'll talk later about the potential role of surgery with extruded nucleus pulposi later. But you can see these after giving contrast. Notice all the scar tissue in here. There's more of a consensus now when you have this much scar tissue going back in, even if there's a disc fragment, as we'll talk about, the surgery may not be indicated because, as we'll talk about, extruded fragment, if it's nucleus pulposus, it will resorb. If it's fibrous tissue, then it won't. But most of the extruded fragments are going to be nucleus pulposus, which is more of a soft tissue type.
Surgery would be on a clinical basis.
Right.
So not on the MRI findings.
Okay, so going a little bit further, this was just information from 1991. Back pain, there were 65 million Americans. At that time, there were about right around 200 million Americans. So you can see that a very high percentage of Americans will complain of back pain. And it was the most important, most common cause of disability. And still in this day and age, in terms of litigation after trauma and in cases of work compensation, back pain is still the single most common litigated symptom patients have. And in 1991, it was over the cost of medical care for back pain was over $100 billion at that time. I'm sure it's double that right now. If you go back in the medical literature, it turns out that back pain was a very unusual complaint in the medical literature before 1900. It's rarely due to a single event, and it's probably now more evidence mostly from the fact there were a much more sedate population now than we were in 1900. In 1900, most people were active. Their work entitled doing a lot of physical activity, and there's just an overwhelming amount of data now that the physical activity is actually very beneficial to keep people from getting back pain. And as we'll talk about later, if you look at all the studies in the literature right now, the only ones that actually show a significant improvement in patient outcomes are ones where walking or bike riding is a substantial part of the intervention, more so than surgery. So it's very clear that lack of exercise is a major component of the development of degenerative change of the spine and back pain. And we'll talk why.
Can I cut in a little bit, John?
Absolutely.
Mountain climbers go to the Himalayas. That's a common place to climb mountains and have their jollies. But Sherpas are the ones that do all the work. They're the guys that carry the loads on their backs that are up to 150 pounds. Now, an orthopedic surgeon way back when was having a conversation, and I was listening, and he asked one of the Sherpas why was it that they did complain about their back, carrying that kind of load up hills, and never complained that they had back pain. And the reply was that that's normal. I mean, anybody that they said, if you carry that kind of weight, of course we have back pain, but we just don't complain about it. It's normal. And that was a big lesson to the orthopedic surgeon who spread the word in lectures around the country at meetings. And that's very true. Activities is a good thing, and back pain is normal.
Okay, great. So a lot of people talk about sciatica. By definition, it's pain that radiates from the buttocks downward along the course of the sciatic nerve. There are a lot of causes that could produce sciatica. And here you can see the course of the sciatic nerve that you're all familiar with. And there are a number of different things, from herpes infections to any forms of compression of the nerve along the process, which can do it. And sciatica is often thought by some people to be a significant reason why you might do surgery, especially if you can see that there is a surgically correctable cause of compression of a nerve along at the L4, L5, or S1 levels, which could be causing the sciatica. And we'll come back to that. Now, the other thing that you can get, so that's radiating pain down the leg. The other thing that you can get is just straight back pain. The etiology of back pain can be many different reasons, including psychological reasons. And if you look at just straight back pain, most of these are not really surgically correctable. So some people will say if you have sciatica, you've got to think about possible surgery. If you have just back pain that doesn't radiate, then it's most likely going to be a non-surgical lesion, unless you have a mass or something that would be unusual, or an infection that needed to be drained, which is quite unusual. So now, so getting back to the muscles, so there is more and more evidence to show that atrophy of the muscles leads to the lack of being able to control the different segments of the spine properly. If the muscles can't control the positions of the bones, then they will slip, and the ligaments in the capsule of the between the bones tend to hold the bones together. Those structures are not designed well, one, that they only constrain the bone at the extremes of what would be considered normal motion. And if you have constant stretch on them, they're really not designed to do that, because the body's designed for the muscles to put the bones in proper position, and only rarely would the muscles not work, and leading to the constraints, which are the fixed constraints, which would be the ligaments. But what happens if you sit all day long in front of a reading station? You tend to slouch, you relax the muscles become atrophic, and the bones now in the spine will now shift, and they'll stretch on the ligamentous structures in the capsules. And this then, the static elements start limiting the stability of the spine, and you start developing injuries to the ligaments and the annulus of the disc. Then one theory is that when you start getting injuries of the ligaments and the disc, especially the annulus, that leads to a weakening in the annulus of the disc itself, which then, when you have increased pressure within the nucleus pulposus centrally, the nucleus pulposus, which is a gelatin-type structure, can then herniate through these defects in the annulus that are due from abnormal posturing and positioning.
There's loss of nourishment due to loss of blood supply when you're not active and just in bed.
Yep.
That's one of the problems. And I think that's how you degenerate. The nourishment is just not there. It takes protein to go from where it's supposed to be to the center of the disc a year. So it's a slow process. It's a pretty rapid process to degenerate the disc, but it's a slow process to recover it.
Okay. And so why don't we start here tomorrow? Here we can see all the different joints. There, as you all know, a huge number of joints in the spine, all up and down. You've got the disc itself and its annular fibers, and then you have the facet joints. And then you have a tremendous number of different tendons and muscles which attach to make sure that all these segments function properly. And obviously normal physiologic motion requires that. You've got to be able to rotate, you have to be able to flex and extend and so forth. And for all that to work together, it requires a coordination of the muscles, and the muscles have to be up to the job. And
never forget there are nerves all over the damn place around the spine.
Right. So the strength and stamina of the spinae erecti muscles are probably really very important for maintaining proper function and protecting the spine from developing a repetitive trauma, which leads to degenerative disease.
So, sorry, sometimes we have like a lot of atrophy in some of the muscles about the spine, like kind of focally, whereas like elsewhere it's not bad. Do you expect the pain then to be in that region, or is not necessarily related?
I think that muscle atrophy that we'll talk about next time is a significant factor in the fact that the spinal segments are no longer properly maintained in position. I think it leads to trauma involving the facet joints and trauma of the annular ligaments of the discs, which lead to degenerative changes in both of those, and that can be up and down the spine. So I think the pain can come from the facet joints, which I think is a common cause. It can come from the annular fibers, all of which are innervated. It can also come from the muscles themselves. When you have weak muscles, the muscles themselves could easily be strained, and they can be painful. And I think a lot of the shoulder pain in people who say they can't sleep at night, you get an MR scan, the tendons are intact, but when you have a lot of fatty atrophy within the muscles, I think you develop muscle strains and weakness. And I think one of the reasons why a lot of people like myself, who may or may not have small tears of the rotator cuff like I have, can get pain. And if you go back and exercise in the gym and do physical therapy, that can relieve a huge amount of the pain. Certainly more so than can be explained by the fact that it does something to the ligament, to the tendon that's torn. I think the muscles are a substantial source of pain in the musculoskeletal system. It's often ignored.
Thank you. But in the spine, then I think it's what you're saying is that you can have atrophy at one level and then pain related to the cascade of ligamentous laxity at another level.
Right. And the problem is when you have surgery is that you, as we'll talk about, is you cut a lot of the nerves that go to these muscles, and you get segmental severe atrophy after surgery, which means then you got complete lack of muscular control over the different segments. And I think that's one of another reasons why you can have a lot of post-operative changes that are not favorable to the patient. So why don't we stop here and we'll carry up this conversation tomorrow. Okay? Any questions?
Thank you.
Thanks, John.
Have a good evening, everyone.
Thank you.
Thank you. Good evening.